Hi everyone. Today is my turn to give you a short video clip on an overdose scenario. This is a patient that was brought to me by EMS in the last couple of weeks, and I've seen similar cases previously. There was a young lady whose brother had contacted EMS after receiving a text message where she talked about taking a couple pills, drinking some NyQuil, and wanted to take a nap. On EMS arrival, nothing was obvious on exam. Awake, alert, appropriate, cooperative. Deny, didn't appear to be under the influence of anything. Said that it was misinterpreted and that she didn't want to harm herself. She wanted to refuse transport. They did not allow that. She did get brought into the emergency department. I saw her as soon as she arrived. I agreed. Her exam was unremarkable. Awake, alert, appropriate, cooperative, did not appear to be under the influence of any substance. Denied depression, feeling suicidal, any prior history of depression, denied any suicide attempt. She gave me the same information about the ibuprofen and the NyQuil, and wanted to leave the emergency department, did not want to be evaluated. I felt she needed further evaluation, including laboratories, and based on what we do for screening for these types of scenarios, I ordered what I routinely order: blood count, blood chemistry, acetaminophen level, brand name Tylenol, salicylate, alcohol, urine toxicology, and a couple of other things, just as what we do routinely for these patients. We modify sometimes what we order based on additional history we've gotten, but what I ordered for her was typically the minimum that we're starting with. Early on, the acetaminophen level was elevated, and although there's acetaminophen in the NyQuil that she took, not to this degree. Re-interviewed, still denied. We base our treatment for acetaminophen overdose to avoid liver toxicity on a 4-hour post-ingestion level. I couldn't determine what that timing would be, so I ordered a repeat level in less than 2 hours, and by then it had reached the toxic range. So that triggered the IV antidote and acetylcysteine, which infuses intravenously over several hours in the ICU. So she was admitted to the ICU. Later, she actually admitted to me that she had researched this overdose. She knew that there was a high likelihood of liver toxicity, liver failure, and ultimately death. She had not intended her brother to contact EMS, and when she told me what the text said, I was glad that he had, but I could see why he wouldn't have if he didn't. When EMS got there, she thought she'd be able to refuse. When she couldn't refuse and came here, she thought she'd get through our screening and be discharged so that she would go home and suffer the liver toxicity, liver failure, and death. That was her plan. But because of layer number 1, which is you guys, she got to the emergency department. Because we do things by protocol, she got to the ICU on treatment, and because she survived that, she actually made it to probably one of the more important steps, which is treatment for her mental health condition. So this case plays over and over again. I've seen it a few times in my career. I'll see it again. It's one of the reasons that we do things in a stepwise fashion and by protocol. We need objective evidence. We need to rule out the life threats. So thanks for your help with this case. I hope you enjoy the rest of the CE. Take it away, Dr. Mel.
Okay, so this is a overdose case that I have. It actually involves 3 patients that EMS brought in within an hour and a half. EMS got called to a festival, and it was kind of like a rave festival. So all these patients were between their late teens and early 20s. The first one was male, and they got called for someone that was seizing. They got there, the patient was seizing. He was very tachycardic on the monitor. They could not get an IV. I think they gave him some Versed nasally, and they just drove very fast to the hospital, and that was about it. When the patient got there, he was actively seizing. He was red, diaphoretic, and extremely tachycardic in like the high 100s, low 200s. Put him on the monitor. My nurses were able to get 2 IVs in him. His temperature was about 42 rectally, so I think that's like 104, 106.
It's greater than 104,
it's
yeah.
A hell
I think
of a
it's
lot.
closer
I feel
to
like
106.
It was like 108. Like 106 to 108 is what I remember. I think
that's not normal.
Yeah, so, and was seizing. So we gave the patient a ton of Ativan. We started fluids. We did blood work and everything like that. We RSI'd the patient, intubated the patient. And then started our workup, but the patient continued to be in VTAC, which is what he was on the monitor. When they said he was tachycardic, he was in VTAC, and he remained in VTAC for probably an hour and a half. And we provided all ACLS care that you could think of for VTAC for a solid hour and a half, had cardiology there, shocks, the whole bit. That patient ended up passing. Now, that was actually, I was in the department that was run by one of my partners because that was an hour and a half.
So this is Benazir. She's one of my colleagues in the ED, and she was going to share with you some information on an interesting overdose situation that she has taken care of recently.
Yes.
Go ahead, Benazir.
First of all, thank you for all you do. Always feel free to introduce yourselves. Really enjoy working with all of you and all the information you provide us, which makes our job a lot easier. So my case was a gentleman that presented, well, we were called for an overdose, but the patient became agitated, was refusing any EMS care. They were having some difficulty getting him to cooperate after administering Narcan. So of course, as typical ER fashion, a lot of us were rolling our eyes at this overdose that was coming in agitated. We're here to help you, let us help you. Comes in, he was again being difficult with nursing staff. Eventually, after getting him stabilized, and I was in the room after talking to him, and I actually didn't even directly ask him this, but what happened to be in the room when the third or fourth nurse who was in the room point blank asked him, "Are you depressed? Did you do this to end your life? Did you do this to hurt yourself?" And the patient's demeanor completely changed, and he admitted to us that he did. So this was a real learning point for me, because yes, these patients can get mundane in the sense we see, unfortunately, a lot of it, but a lot of times we miss something like this, and that's a perfect opportunity for us to step in and help out. Yes, we could have treated his overdose and discharged him, but he could have done it again and really taken his life. So that patient, we were able to get him in the right hands for a psychiatric assessment and then help moving forward. So that's my interesting case to keep in mind.
So I had the following two patients. One of them was female, came in seizing, tachycardic, but not in VTAC, and very hot to the touch. They were able to establish an IV. They gave her some Versed. She was still seizing. When she came to me, she was intubated, and then she was rapidly cooled. She was, her temperature I know was 106 or 108, and
This is Dr. Patadia, one of my colleagues from the ER over at Good Sam. He has another overdose scenario he was going to share with you.
So, you guys probably have had a lot of boring material that has talked about the pathophysiology of it all, but I think the most important thing is history taking, and remember to keep your differential broad. So anytime you have somebody that you don't know what's going on, throw a tox type workup in there, kind of think through it, think about medications, anything around the house that people could have gotten into. And the case that I'm going to tell you about is a case of a pediatric child around a toddler age. I think it was around 2 years of age. Came in, mother brought the child in, and they were extremely lethargic. They were kind of falling over. They didn't know what was going on. The child was afebrile at the time. And, right out of the gate, you're like, oh, this is a tox case. But if you're just looking at a case where a kid comes in and they're lethargic, not feeling well, it takes you down a totally different path. So what we did was we wound up going down an infectious path, wound up doing blood cultures, straight cath urine, went all the way down to even doing a lumbar puncture on the child, which wound up being negative, did a CAT scan, okay, which was obvious radiation exposure, and eventually we came up with nothing. Finally, the father, who had not been there the whole time, comes in and had made either some brownies or there was some sort of marijuana-based ingredient that toddler had gotten their hands into. And sure enough, when we did the urine tox, it was positive for marijuana. So remember, even things like marijuana, which is an illicit drug, could be a tox ingestion or present as a tox ingestion. And you have to keep that differential broad, because tox ingestions can look like infectious, altered mental status, weak. It could look like a stroke, could look like a psychosis, all of it. So remember to keep that differential broad. And remember, illicit drugs are tox ingestions.
then there was a third patient that came in, male, seizing, high temperature, They did give him Versed and fluids, and he was able to slightly wake up, but still tachycardic, very hot. So because of the type of festival this was, and because of a
Demonstrate the music again. Okay, we got it.
Okay, it was that and I lived right by it, and you could hear it for like 2 solid days. And it was very hot outside, so they thought it could just be exhaustion, heat exhaustion, those types of things. So we know from my experience that this festival has polypharmacy there. So when you think of the different toxidromes, well, it's not opiates because those people are normally out of it, not seizing. It's not necessarily alcohol because you can't have that high of a temperature with alcohol, and you only withdraw from alcohol and have a seizure. What else is it? Could it be cocaine? Cocaine, you're very, very, very tachycardic, but you don't really necessarily get that hot and that febrile from cocaine. So what we had learned, because one of the friends came in and he said, we asked, did she do any drugs today? He said, she did ecstasy, because at concerts they go, there's alcohol in ecstasy because ecstasy makes those things fantastic. Now, specifically that year, it was a yellow pill with Bart Simpson stamped on it, and those 3 had that. So obviously these are all synthetic. So all 3 of these cases were synthetic ecstasy that was just lethal to these patients. My patients survived. The big things were getting the patient cooled. That was the biggest thing for me, is getting them cooled and also just getting their respiration stabilized, because the first one, she couldn't stop sneezing, so we needed to make sure that we were aggressive with her airway. So I did an RSI and intubated her, made sure her blood sugar was okay, and I just gave her a ton of cold fluids. And then we initially just put the ice packs between her underarms, by her neck, in between her thighs, and we put the cooling blanket on her right away. When we got her temperature down, everything started to stabilize, but she actually did end up going into shock liver. Her liver function enzymes were pretty bad that day. We kept her. They kept going up. She ended up getting transferred to the liver center because they thought about a possible transplant. She ended up doing okay. She survived. The second guy that I had that was a seizure that seemed to wake up that I didn't have to intubate, we kind of knew it was coming in because of the first 2 cases. And so I was able to get a second cooling blanket in there. So we slapped the cooling blanket on him right away. We had already put fluids in the refrigerator. So we were giving him fluids, and we gave him Ativan. And he got to the point where he was awake enough that he was trying to sign out AMA from the ER about 4 hours later.
I gotta go back.
And
I need more.
And his liver enzymes were still abnormal. His bicarb was really low. So he got admitted to the intensive care unit. But he obviously ended up doing okay. Now, the first case that went to my partner, that was the guy that was in VTAC for at least an hour and a half. And I don't know if they were able to put the actual cooling blanket on him, because were doing CPR because he was in VTAC, but they tried to put everything in, the cool fluids, the ice packs and everything there, but because of the CPR, because of the shocks and all of that, he couldn't necessarily have the cooling blanket on. But he got thrown every antiarrhythmic in the book, tons of shocks, all that kind of stuff, and he just didn't survive. I mean, he didn't survive after that. So for EMS wise, for these people, my advice would be, if you're thinking of anyone that they're big on raves, anything that has like the big lights, anything raves, that's a big thing now is ecstasy. They're going to be altered, they can be seizing, tachycardic, they're going to feel really hot to the touch, their skin's going to be red, they can be very, very diaphoretic. One thing is, so if they're seizing, you make sure you protect their airway and give them Ativan. And I don't know if there's necessarily enough Ativan that you can give these people, because they're on fire. So
Versed pre-hospital.
Yeah, so Versed would be great if you can do that. But the other thing is just start cooling the patient, take all of their clothes off, cut everything off, and as many ice packs as you can have, just start cooling them. Put ice packs all over their body, put the air conditioning on really high. And obviously you can't cool the fluids, but rapid fluids and cooling is the thing you can do pre-hospitally. Also, please make sure you check their blood sugar, because this can really lower their blood sugar in multiple cases. the VTAC thing, you can start off with, I mean, I know they normally say with this type of VTAC to try to just give lidocaine first. I also was a medic starting, 20 years ago, so lidocaine was more before amnio, because you also don't want to give amnio if you're thinking they have torsades. If they have low magnesium, because you also think it was an alcohol and they have low magnesium, is this torsades? Because amnio is really bad for torsades, so lidocaine is kind of the safer option when you do have that type of overdose. So those would be my recommendations. I can't really remember what their pupils looked like. I feel like they were
So
seasoned.
take home, I
They
think
were
you
seasoned.
covered right out of the gate ABCs,
Right.
and then start figuring out, are you clearly in a toxicrome? Maybe you're in a mixed situation,
Right.
and you're treating the life threats first.
Yeah.
Sort
And
the rest out later.
tachycardia might be very, very difficult to control because there's so